you have learned a lot about PBC. It's a very comprehensive talk. And this is the summary of PBC, and probably you may be very familiar with this. And my title is PBC and Eastern View. But actually, we believe that there is no significant difference in terms of presentation or pathogenesis and long-term outcome of PBC between Eastern countries and Western countries. But so please allow me to talk about several overlap between Gideon's talk and mine. But probably there are small difference in terms of epidemiology or treatment strategy for PBC between Eastern and Western countries. And I'd like to focus on these similarities and dissimilarities. So let's start with the epidemiology in the East. So this is the summary of epidemiological data on PBC in Asian countries, the prevalence and incidence and male to female ratio. And in some countries, for instance, Korea, Japan, and Hong Kong, Australia, there are two data over time. For instance, in Korea, prevalence was estimated in 2019 and 9 and 2019. And as you see, the prevalence is increased all over the Asia, and incidence is also increasing. And by contrast, the male to female ratio is going down. For instance, in Korea, male to female ratio was reported at around 7 in 2009, and in 2019, the male to female ratio is going down to 5 to 7. And in Japan, the ratio was 7 in 2004, but after 12 years, in 2016, the ratio was down to 4. So it seems that apparently the male patients are increasing in all over the Asia. So this is not the phenomenon only in Asia, but also observed in the Western countries. And so let's talk about etiology. As you learned a lot about etiology of pathogens of PBC from the Gideon's talk, so PBC developed from the genetic predisposition and environmental factors. And among genetic factors, a number of predisposing genes are identified, HLG genes, and the non-HL genes, for instance, IL-12, CCL, and other genes. And for environmental triggers, there are also a number of environmental triggers were identified, including microbiome, and smoking, and genebiotics. So people believe that autoimmune attack against the biliary T cells are central feature of PBC, and leading to cholestasis and fibrosis. So this is the very impressive family tree found in West Asia, reported in 2003. So this mother had no PBC and no AMA, and there are eight sisters and 2 brothers in this family, and you see 5 out of 8 sisters had different PBC with high antibodies, and other 2 sisters had no PBC yet, had weak AMA detected. So it's definitely the genetic factors are contributing to develop PBC not only in this family, but all PBC patients. So probably many of the non-HL risks also express proteins involved in immunological pathways and cell differentiation activation and inflammatory cascades. And so for the moment, according to the Professor Marchand in Shanghai, non-coding codal variant in the 19p33 locus controlled express of ALD3, leading to the dysregulated myelin cell differentiation functions. But also it is clear that genetic factors don't vary over time, so it's very stable. And so why the epidemiological data are changing over time? So, probably we expect that environmental factors, environmental triggers may be changing over time in Japan. So to identify environmental triggers, we conducted the case control studies in Japan to compare several clinical variables between PBC patients and health controls. And we identified that so in all subjects, so boarded toilet and unpaved roads and smoking and hair dye use and autoimmune disease in the family and caesar sections and PBC in epidemiologics were identified as contributing environmental factors. So it's among them, these two closely related with very dirty circumstance. So I'm going to show you the very impressive pictures. So this is, as you may know, so this is very traditional Japanese toilet. Actually, I'm 64 years old, so when I was a kid, so these are very common. And there's another picture. This is the picture of the Osaka station in Japan. But some of you may been to Japan. And so this is a picture of Osaka station about 70 years ago. So this is very dirty circumstances. And so I believe that this environment may be related to the development of PBC. So because the PBC, one of the characteristics of PBC is association with the urinary tract infection. And UTI, as you know, is believed to develop more common in female patients. Yeah, this is so the female dominance in PBC is partly explained by the more frequent development of UTI in female patients. But recently, so the toilet is changing like this. And this is the same place in Osaka after 70 years ago. So the circumstance is getting cleaner and cleaner. So the role of this kind of bacteria disappeared. And indeed, during our case control studies, when we limited the patients only in the younger patients, so no these factors were identified. Only smoking was found as environmental triggers. So we believe that the environmental triggers may be changing over time. And recently, instead of these dirty environment closely related to the bacteria. Currently, another environmental trigger, which is shares commonly between male and the females, are more important for the development of PBC. So, what is the alternative environmental triggers? So one candidate might be a high-fat diet and gut microbiomes. So this is one study from Japan. So they used the PBC model mouse immunized by PDC to one of the autoantigens PBC, and they fed that mouse with a high-fat diet. And they found that immunized with 2OA, autoantigens in PBC, and fed with a high-fat diet, the mice developed severe cholangitis. And the lipocholic acid is increased, and also microbiota has been changing in the mouse. So they speculated that after the high-fat diet, the genetically susceptible mouse may develop PBC through the changing the bile acids and microbiota. And this is another example for showing the importance of microbiota from a show in Shanghai. So they reported that the importance of butyrate, so gut microbiota derived butyrate, and they found that the gut microbiota derived butyrate induced the expansion and function of MDSCs and relying on fatty acid base oxidation. And the MDSCs is a heterogeneous population of immature male cells. It's negatively correlated with disease severity of PBC, and the exposures to butyrate restored dysfunctional MDSCs in UDCA non-responders. So let's move on to the diagnosis of PBC. And but the diagnosis of PBC is not so challenging. So because we have a very good marker for the diagnosis of PBC, antibodies, and also PBC specific anti-nuclear antibody, anti-SP100 and IgG210. But usually, not only in Western countries, in Eastern countries, we can diagnose PBC if the patients meet 2 or 3 of these items: elevation of ALP and gamma GTP, and presence of AMA, and liver histology, typical for PBC. And we don't have to conduct liver histology because we can confirm these two: elevation of ALP and presence of AMP by blood test. Very easy, very simple. So as I talked to you later, so when we encounter the patients with elevated ALP and gamma GTP, and if there is no dilation of intra or extra hepatic bile duct, we should test the antibodies for seeking the possibility of PBC. And the management. So, as Gideon remarked, the PBC is believed to be typical autoimmune liver diseases. So, the starting in the PBC must be the suppressing the autoimmunity against the various epithelial cells and liver inflammation. So, the first strategy for PBC is suppressing the autoimmunity against the BSCs and the inflammation. And the next strategy, following to the first one, is anti-cholestatic agents, and the third, anti-fibrotic agent. But yes, Gideon is right. So we have been trying to suppress the autoimmunity against anti-VEGF cells, but all trials have failed. So this is one of the examples for our failure. Trial with anti-fractalkine CX3-CL1 antibodies for PBC. CX3-CL1 fractalkine expression is upregulated on VEGF cells of patients with PBC via toll-like receptor 3 stimulation. And the counterpart of this fractalkine are CX3-CL1 positive mononuclear cells enter into the liver from proton tracts and excite cholangitis to CX3-CL1. So the fractalkine is very important, very crucial molecules for development of cholangitis in PBC. So our strategy is to suppress this fractalkine and the connection between fractalkine and CX3-CL1 molecular cells with antifractal antibodies. So we conducted the phase 2 clinical trials for patients with PBC with incomplete response to EDCA for these antibodies. We defined the endpoint of this trial with ALP reduction, but however, with the phase 2 clinical trial, this antibody did not demonstrate ALP reduction at all, as you see. So why this failed? Why this? We believe that the strategy is good, but why this failed? So the most relevant reason for this failure is that these patients had very histologically advanced diseases. So we selected the patients with incomplete response to EDCA. But after the trial, we examined the liver histology of these patients, but we found that bile ducts was almost gone in these patients. So bile duct loss was observed in most of the patients. So actually, the strategy is based on the fact that the blocking the fractalkine on the biliary cells, but the biliary cells are gone in these patients. So that's why. So this is one of the reasons for the failure of these clinical trials. So probably to succeed for the success of the clinical trials, we need to find the PBC patient in the very early stage. Probably no fibrosis, and ALP might be normal, and but AMA positive. So for that patient, this drug may work. But anyway, this is not feasible. So currently, the anti-cholestatic agents are mainstay of treatment of PBC. And you have already seen this figure in Gideon's talk. And UDC is approved the first-line treatment for PBC. And so clearly, the long-term outcome is best in the patients with complete response, and followed by the incomplete response and untreated. So when the patients respond EDCA very well, that's it, that's fine. But if the patient's response to EDCA is not good, so we need to treat patients with additional second-line treatment. So what is the second line? So we have used the bisphenol as a de facto secondary treatment for PBC for about more than 20 years. And meantime, so in French groups, Christopher Coppershire demonstrated very nice study in New England Journal of Medicine in 2018. They conducted 2 years prospective randomized control study for this fibrate, and clearly showing that the ALP was reduced and the liver stiffness is improved, and very good results. And after 2 years after that, so we collaborated together, and we analyzed the Japanese retrospective data, and we successfully demonstrated that long-term outcome was better in patients treated with fibrate compared to patients with UDCA monotherapy, as you see. And actually, bisphenol is a very nice drug. So, this is the bisphenol was shown to improve long-term outcome, just like this one. And this is the itch scale. Yes, itch scale. So bisphenol is also reported to improve itch in patients with PBC. And actually, this is very low, very cheap drug, very low cost. So that we believe this is a very nice drug, but by contrast, bisphenol has concern about safety. So during long-term use, the bisphenol develops sometimes the renal toxicity. So secondary treatment, fenofibrate. So this is a report from Sion, and this is the fibrinol and cerebrospinal and phase 3 trial in Japan. So these are unsolved issues for PBC, and in Japan, long-term survival is getting better, but still we have a problem. So we still have the advanced disease at the diagnosis. So obviously the patients with the cirrhosis at presentation have poor outcome in the long run. So we need to diagnose the patients as early as possible. And the symptoms really matters in PBC in Japan as well. Yeah, about 24% of patients had moderate to severe itch, and it does not correlate with the ALP and LV progression. And you have seen these slides before, and we have an tool for pruritus in the patients. So this is the current management policy. We call this response guided or a way to fail. So we start with UDCA, and if the biological response is not good, we add the bisphenol or other secondary drug. But probably we should stratify the risk and predict the risk UDCA response at first, and we should change the treatment strategy depending on the patients. Stratify the treatment strategy. So the earlier diagnosis and definition of relevant in the points, and the patient-reported outcome is very important. And so in the near future, the time-limited regimens are definitely needed. Okay, so this is key takeaways. So thank you very much for your attention, and I'm very happy to take any questions and comments. Thank you.
Thanks so much.